So we're seeing that they have inadequate training for this new policy. So this is also where the Pure Study hopes that these mentor mothers can function somewhat like HSAs do in the community or the facility, but are focused on this policy. Because we're scaling it up so quickly and it's unproven, and we're seeing these rates of loss to follow-up with these early initiators of Option 2+, we really need to support that care. So this is a study that just came out with some interim results, I think 3 weeks ago, and really quite exciting in that this was the gold standard evidence, quote unquote, from a large multinational clinical trial that compared option A to option B and B+. And for the first time really showed that B or B+ is considerably more effective in reducing vertical transmission. So that study is still going. It's primarily done in, obviously, as you can see, sub-Saharan Africa and also in India. So just to end, this is Alice. Alice was our first employee at Dignitas. She's HIV positive and runs our healthcare worker clinic. So this is, back in the early days as Dignitas was just beginning, we really needed to, and this was Adrienne's baby, really needed to prioritize the care of healthcare workers so that they could care for others. So Alice still runs our healthcare worker clinic, an amazing woman. So just to say that there's been some really great successes in the HIV trajectory over the last 10 years. There's still a lot of unanswered questions that Dignitas and many others are exploring. This is Alice's grandson, who was born HIV-free because his mother got put on treatment early. So we'll stop there, and Adrienne, maybe you and I can take some questions. Yeah.
Yeah, I don't know if you can comment on this, but I'm interested in your the situation prior to your entry. I mean, I think most of your problems with individual and government level is that these parties are not very well informed. Maybe like, I mean, the reason maybe the mothers weren't sticking with the treatment is that I don't know how good they're informed about the consequences of the HIV. Like, they are always not very well educated. Maybe I'm wrong, but like in general. So when they come in the first day and they find out that they're HIV positive, they are receiving this consolation, and probably they are getting scared by this nurse too, like about what the consequences can be for the kid. So okay, then they go home with this whole huge trauma to deal with, psychological trauma, and then it's easier to dismiss the whole thing and just try to live like nothing happened. And even the last picture that you showed, the Alice's picture, I mean, she looks nothing like this stereotypical AIDS patient that we come to see in the media, right? Like this very sick person lying on the bed, like nothing like that to be scared. And in the government level, I mean, when you're implementing the policies, I mean, initially you were talking about like how there was this resistance that the evidence has to come from Malawi itself, that like they're not very open from the evidence from outside. I mean, did they identify in the first case that they had an HIV problem, so they asked for a help from WHO, or WHO identified that you guys are having a problem and we are kind of overtaking this, like this is our policy suggestions, and they just want them to sit down on the same table because of who asked the help in the first case. If they didn't ask for the help, like how it is easy to really help them.
So so there's a lot of pieces in that. Let me just start with the beginning, which was kind of how we got involved in the first place. So one of the interesting things, and what I've heard, one of the reasons why we went to work in Malawi was because the policy environment is actually quite receptive to support from other stakeholders. Many of you will know when the HIV epidemic, when attention around at least when global mobilization around the HIV epidemic in Southern Africa kind of started to happen in the early 2000s. Many countries didn't necessarily have that receptive policy environment, though the best example would be South Africa, when Thabo Mbeki didn't even believe that HIV was caused by a virus, right? And there's been lots of really interesting work around that, and the not the health economic impact, and also the health impact of that. Malawi was very different. They knew they had a problem and they wanted help. They were able to put together a grant to get a lot of money from the Global Fund. And where they were at in 2004 was, we know we're going to get hundreds of millions of dollars for the Global Fund to roll out a program. We just don't have the human resources to do it. And so a huge piece of us, when we went to the Malawi government, because we were looking at it was an idea on a piece of paper in 2003. Our founders went to a few different countries, and when they went, they initially actually wanted to focus more, at that time because treatment hadn't been rolled out, they wanted to focus more on supporting the community-based, home-based support, like the palliative work that was being done. So when they went to the government, and there was a very good technical advisor at the time, so this is interesting how individuals can sometimes make a difference. Professor Harries he's a British pulmonologist who basically worked in Malawi for 25 years, and he was the architect, really, of their HIV response. He was in the Department of HIV/AIDS, put in there as their technical advisor for treatment and care. He was the architect of that response. They approached Tony and said, hey, we're this NGO, we're these Canadians, I'm James Orbinski, blah, blah, blah. And Tony said, well, that's great that you want to do home-based care programs, but right now we need NGOs to help us actually do what we've planned. So the Malawi Ministry of Health had a plan. They came up with a monitoring evaluation plan. They came up with standardized guidelines. They just needed people to help them implement that plan, and that's kind of where we came in. So that's a really nice example of where, as an outside stakeholder, you can come in thinking you know what you want to do. And where you can sometimes find synergy with a government who wants to do something but can't necessarily bring in the resources. I think the Malawi government has been a really nice example of someone who doesn't necessarily have all the resources but has taken control over the response. Even when Doctors Without Borders comes in, they sometimes like to do their own thing, but the Ministry of Health has said, okay, you're going to do it using our guidelines, and we're going to assign you to this district, and then you're going to go to that district. And we all kind of come together. So it's not like our response. And the reason why we sometimes keep accidentally slipping out of and referring to the ministry, is the Ministries of Health's response. So your other question, which was about kind of what's happening at the personal level around treatment preparedness, I agree that treatment preparedness is tricky. That there are programs that are devoted to things like community sensitization, information, education, and counseling. We didn't get into that because we were just focused on the biomedical piece. So there's a lot of people that are looking into social marketing and communication around treatment preparedness, but I think you're right. I think women are still sometimes showing up and being a bit shocked by the diagnosis and what that means in terms of treatment. Alice is that whole kind of what stereotypical HIV patients look like. What is amazing about the HIV program in general, and what is in some ways sad that it didn't happen 10 years earlier because treatment was available in 1996 here and it took 10 years to get over there, is that you go, and I've literally seen it, having been in Africa in 2005 and seeing what it was like to see like skeletal patients dying of AIDS, and then going into a clinic, and if you walk into our clinic, everyone looks like Alice, healthy, it looks like an outpatient clinic. The same thing like what's happening here. So I think that ART is a really good example of a biomedical intervention that can have major impacts, not just on health, but on economic productivity as well. So
yeah, and just to say, that there's actually studies out there that show that education and the awareness of HIV in Malawi are pretty good. It's do you think it's going to happen to you? And are you in that space right when you're going into your first antenatal care visit? So it's even if it's you know that you need to stay in treatment for life, there's a lot of competing pieces there that make it quite complex.
And I think the health system isn't built up to provide individual care to the degree like we're used to here. Right. Not at all, right? We're really looking at it from a public health perspective, which is very, very different than kind of how we view individualized
Sit down.
medicine here.
Yeah, sorry, I think back there was. Yeah.
Thanks. Thanks to you both for a really great presentation. I guess as someone who is trying to understand how policies are socially constructed in aid organizations, how they're created, implemented, and evaluated, option B, so is it a program, model of care, policy, or strategy? And what is the distinction that you make between those different terms? Because I heard a few different things throughout the presentation. I'm just curious.
Say the terms again.
Program, model of care, policy, strategy. Do you make any distinction between those?
It's a program.
Right.
It's a policy. It's
So-
also like an actual like it's referring to an actual.
Yeah, my sense in our work in Malawi that a lot of those terms are at least used interchangeably on a day-to-day basis. I think you can make distinctions, but I would say often by people that aren't maybe specializing in what you're specializing in, it's an interchangeable phrase.
In between policy and guidelines?
So it is, I think that people refer, what actual option B plus is basically putting a woman on triple therapy for life, which is, so that it was adopted as a policy. The Ministry of Health has referred to it as a policy in some of the literature that comes out. And
then there's a guideline.
There are guidelines about how it should be implemented.
And the models of care study that Dignitas and Adrienne were part of tried to look at the implementation of that guideline. Yeah.
Sorry, what are you guys doing?
Go ahead.
Oh, I did completely different question.
I think it's okay.
3 people waiting for questions, so
Yeah.
at
Yes.
least.
Do you want to? Yeah.
No, I don't.
Yeah. Let's keep going. Yeah.
Am I next in line or should I?
I don't know. Let's go with you.
Just
I
go
think
with
so.
you.
Yeah.
You
there was-
are now.
There was actually a tie, but I'll give it to you.
Okay, thanks. This might be kind of a sensitive question, but do you believe that the money is justified going to B plus instead of just doing the program B? Because you were saying that the infant survival rate for infants with HIV and without HIV are relatively similar, so maybe the money should best be put into like increasing their standards of living, so they do have like higher infant survival rates. And also, I know there's like you said there was an average of 5 births like per woman. That's like 5 years, and a woman's fertility period is like what, like 30. So like, do you think it's justified to do program B plus instead of B? I don't know. It kind of might be sensitive because it seems like you guys.
It's not sensitive. It's not sensitive at all. I think those are
Yeah.
good questions that people don't totally know the answer to. I think there are people who've done cost-effective analyses, and depending on who, there's actually cost depending. I'm not an economist. In fact, I'm not sure I could calculate my way out of a tin can. But basically, I work with economics colleagues, and I've seen people come up with models that support one and models that support the other, because it really depends on what you put into
It's your
it.
inputs, and
Yeah.
you could make the same argument that so Malawi has put forth a policy program, whatever you want to call it, that prioritizes one group over others. So women are getting on treatment as soon as they know they're positive and pregnant, and
And
male
taking resources away from men, for example,
aren't getting on
who we know
treatment
are
until they're
getting on
sick.
treatments later, yeah.
So it's so just one more thing. So it's a complicated question.
It is a good
And the other piece, you mentioned kind of raising their standard of living or some kind of economic development. Those are all possible. The way that a lot of these things are funneled doesn't give the government or anyone really that type of flexibility to say, I have $100 million, what am I going to do with it? What's going to be most beneficial to my country as a whole? It's obviously, it's these things can go into funding this specific, biomedical intervention, or this can go into something else. So it's not a free for all.
The other thing that's interesting too, just thinking again from the research to policy angle, is I noticed from the policymaker's perspective that whereas there used to be a whole lot of interest in looking at randomized control trials to show policy impact, there's been a real shift recently, at least in HIV policy, making towards more like doing modeling. And so that's what I found in terms of how they're doing decision making. So, but I also, part of me having seen it like over the last decade and a bit is just that it just seems to be a bit of a flavor of the month over kind of what people will listen to in terms of impact. In the end, the way I think about it philosophically is like, making these kinds of arguments, I know what we do here in Canada, right? And I don't see why what we've decided, morally or ethically as a physician or public health person is, considered standard of care here, why we don't consider that to be standard of care there. That's how I look at it in a very simplistic way. It might not be the way an economist would look at it, but from an ethical perspective, that's how I see it. That I shouldn't have to be forced to choose between B and B plus or between men and women. I should be able to provide them all with care like the way I do here.
Let's get to two other questions. Yeah.
Yeah, I was interested in the decision to adopt B over A, especially with the influence of the UNC studies that it was actually Malawi. So if you could maybe paint more a fuller picture, like who were the actors involved in that decision? Was it a contentious process? Was it like one symposium over many? Any details?
We have to turn off everything.
It's okay. I think they'd be open about it. There's people actually looking at it.
Right. Yeah. It's interesting how these policy processes occur. Kaylin and your group, you've seen this in many countries. It's often relationships, it's often timeliness of when something gets put forward, who shows up at meetings. The strong argument, as Adrienne pointed out, for B+ was the simplicity of it. And my sense is, and Adrienne, you can expand on this, that's really what sold key decision makers. Yeah. Is that we were seeing firsthand that the complexity of the current PMTC regimen in Malawi wasn't working at all. And option A was going to simplify it, but it was still going to be, because of women having multiple pregnancies, going to be on and off, and that was going to still be complex. And could you start this public health approach, test and treat, and have the possibility of great outcomes, supporting it through the Global Fund, and simplifying it in a way that that frontline healthcare workers are very clear on their direction.
And also I think if you talk to the various people that were involved in the discussions, they will give you a different picture of what they actually thought was happening. But what a lot of it is the relationships between people and how it works in a group. So the technical working group basically had set up meetings with the various stakeholders, which include Ministry of Health people and also NGO people, to discuss the WHO recommendations. And we would break up into small groups to discuss various aspects. People would argue it out, and then everyone would go, the Ministry of Health would go and do something, and then we'd meet up again. And it's were those meetings idea generating, or did someone have an agenda and push that agenda during those meetings and use them as consensus building sessions? I still don't know the answer to that question, and I think about it in the context, there's a PhD student in San Francisco who's doing her whole PhD on this, where she's interviewing all the various stakeholders, and I'm curious what she would come up with, because she's had a chance to interview various people. There were some very strong opinions, technical advisors. A couple of them were like expatriate technical advisors that had been in the country, again, for more than 20 years, who had very strong opinions about it. Eric Schau, did Eric's opinion push things along? I don't know the answer to that question, because I also felt like people like us, like MSF, like the Baylor folks, were very interested in pushing this forward too, because we knew how complicated it would be. Mina, who was from UNC, was very irritated that nobody was kind of taking on A. For a while, when we thought that there would be a lag time in terms of them reappropriating the budgeting in order to get the drugs for B+, we thought, let's just implement A. But the Ministry of Health, and in fact, I remember Eric in particular was like, no, we don't want to do that, it's going to be too confusing. So that was a decision taken by the Ministry of Health, but that may or may not have been everybody in the Ministry of Health, or may have been one individual. And I don't think any of us could ever know. I'm not sure you'd even get an honest answer from the people who were involved. Yes?
So Mike had a question. We're running out of time. We have a buffer period, but I'm just cognizant of the fact you guys have to be in Toronto.
Just a couple,
So Mike?
Great presentation, thanks. So I just had a question about how much of the adoption of B+, whether it's in Malawi or other countries, is actually at least partially a spillover effect of the general push towards treatment as prevention. And I guess the sub-question is, what has been, or has there been any signaling around the risk factors associated with treatment as prevention, and the impacts of that on future HIV transmission down the road, not just mother-to-child transmission, because of the essentially the context is that adherence is an incredibly significant predictor of whether treatment as prevention is actually going to work, even though we're telling people we should be doing it. But that's only
Yeah, I feel like you made the argument there, right? I mean, it's. I think people are seeing this as an experiment with treatment as prevention in a cohort that has regular follow-up and really good access, in theory at least, to care throughout a sustained time period during pregnancy.
right.
So is this testing for treatment as prevention on a larger scale? I think you can make that argument pretty clearly.
And I think there is good signaling that I think in the next iteration of guidelines, you're going to start seeing like WHO always lags a few years behind what goes on in the rest of in like North America, because they don't want to set the standards too high that low resource studies can't meet them. But my sense is that by 2016, 2017, you're going to start seeing a push towards like what we're seeing here, which is that everybody should be offered treatment once they're diagnosed and if they're ready. I think the piece that is missing is how do you define and if they're ready?
And if they're ready, right? Because that's what we're.
There is no, because I find the one thing I would say in Malawi is the way the human resources for health is, there is no space for that if they're ready piece that we have here. Like there's lots of patients I counsel, if they're not ready I send them off, they come back when it's time. At some point they'll reaccess the healthcare system. In Malawi, you could lose them and never get them back again. So there's this huge push to kind of aggressively get people on treatment and bring them back, just because the resources are so limited. It's such a different context that I think I don't think we fully understand how it will play out and what the impact will be on adherence, which is why a lot of the research that's being done around this is so important, because it gives us a glimpse of what could happen if treatment as prevention gets kind of rolled out on a wider scale.
Because in that regard, it's a risky policy.
It is. Well, yes, I think so.
Well, that's my concern
Yeah.
because a lot of the evaluations around treatment as prevention are done in these very.
Yeah.
A lot of it's been done in Canada. It's done in a very controlled
Yeah.
setting in BC, where everyone is
Yeah.
offered free antiretrovirals, and they only include people who are adherent in their studies. So, I guess I just have this raised some concerns about broader rollout of that and what that means in terms of signaling to people about risk down the road.
Yeah, I agree. I also think that's why there's so much interest in this, right? Is because this is a subpopulation in which they can learn pieces of information about where things are going in the future. But what I've heard from people is that, and if you'd asked 5 years ago when Montana started talking about treatment as prevention, I was like, don't be ridiculous. Like this is so, we can't even get the people who need to be on treatment onto treatment. The way in which B+ has been rolled out in the country, I mean, there's like 500,000 people on treatment now, right? So when we did those studies, I think I said it was about 100,000.
Yeah.
There have been 500,000 enrolled in that country. So in over the span of 10 years, we've gone from 3,000 people on treatment to over 500,000. So I think I never would have thought that kind of scale would have been possible. Now that I've seen that can happen, then I do feel like that leading into treatment as prevention might be a more feasible goal than I would have thought 5 years ago in our setting.
But there's a lot to learn.
There is, knowing that there's still a lot to learn, and that, you know, for every good thing you think you do, there's like many downstream bad consequences that you need to always keep an eye on. So that we learn the hard way, I think. So.
Should we do one last question? Anybody else?
Yeah, we have one. Marsha,
I treatment as prevention.
okay.
We got
We
it.
have another one here, and then one more if we have.
Sure.
If we can make it quick and snappy, is that okay? Okay.
For us too.
Okay.
No, that's me.
So I'm just wondering, you mentioned that I think there's like a lack of like psychosocial services for the people who are accessing this treatment. I actually volunteered in Malawi last year for like a few months, and the organization I worked with, they had a lot of like supports for people with HIV, so like having them like create like 8 support groups for them and that kind of thing. So I'm wondering if you worked with any like local NGOs to kind of, I guess, fill in the missing gaps there.
We used to do a lot of work with the community-based organizations, like primarily that's what we did to start off with in terms of AIDS support organizations. I think my sense is that it's these small programs work beautifully. Putting it to scale is where the challenge is. And so one of our interests in looking at, you know, one of the things that the Malawi Ministry of Health has been able to put to scale are these health surveillance assistants, right? It's a formalized cadre of healthcare worker to which certain health promotion activities have been task shifted. our question is, could that be cash shifted to things like pure health workers, which is why we're very interested in this expert patient mother cadre. Would that be something that the Ministry of Health would be interested in funding? That's why we'd be looking into research around it, because it seems like something that might be able to kind of be put forward to scale. There's a lot of interest also in community ART groups, which MSF has really piloted initially in Mozambique, but there's a lot of interest in bringing that to scale as well. The question is just figuring out what's the best way to resource them in a sustainable way, and also in a systematic way, as opposed to just like
chunks, which you see a lot of.
programming.
Yeah, and the other argument I would make, so we don't do, to answer really your question, we don't do as much now as we did in the past.
Yeah.
The argument that I've made is that there's a lot of players, especially in Malawi, that are working in these types of areas, and I get frustrated when I see organizations do this and start to get into things that they're not really that great at.
We weren't that great at it.
And we weren't that great at it. And I think where I support Dignitas' work is that we do what we do, and I think we do it quite well. And there's others that are kind of playing that role. And then we need to work with them to partner and make sure that there's a continuity of patients, because the patient doesn't care who's supporting them, whether it's a local NGO, Dignitas, the Ministry of Health. I mean, it's all the same. So there's that partnership role that we continue to try to fill.
Is there one last question before
Sure.
we get out of here? Because
Sure.
I don't want you guys speeding on the 403.
Yeah, 3, whatever, yeah.
To the QEW. Laura?
Well, this is probably another topic for this number seminar, but you mentioned, I was wondering about the role of the father and the adherence and that kind of, because you mentioned if you give birth to or you're pregnant, you go to the clinic and you discover that you're HIV positive, that would suggest things about your husband that perhaps you weren't anticipating. So, I mean, I get how you'd be unwilling to bring tough issues. Is that part of the whole, or is that a whole other
It is. I mean,
agency, or how does that fit in?
I think it's something the Ministry of Health is interested in. It's just figuring out how to resource that. Some programs, so within our 6 districts that we work in, you see one of the indicators is couples counseling and the number of people that get tested with their partner. And certain districts do better than others, and it's often related to targeted programming. So incentivization, for example, of bringing in male partners for testing. One of the districts, Clinton Foundation, was doing a WASH program where they were giving out hygiene kits to men who came for testing along with their wives. So one of the fall-on effects was that women were just randomly going out and grabbing men to come to the clinic to get tested with them so they could get the WASH kits. So then it would it was their partner, but it wasn't really their partner. So these interesting things are kind of happening, and there's been a real interest in increasing male involvement through male-targeted programming. There's a Malawian social scientist, Jeremiah, who's based out of the Malawi Liverpool Wellcome Trust, who's been doing a lot of work around that. Right now, I think it's in a small program level, not at a scalable level. At the nationally, of course, there's talk about increasing male involvement. Whether that's how that's getting translated into how a program is being implemented right now, it's very pilot programs, but nothing done on a larger scale beyond bringing in the couples counseling piece. But I think they're interested in bringing that in future iterations and in future guidelines, trying to make it more of a hard indicator.
Because you're right, it's a huge piece
it's
for
a huge piece.
for the successful implementation of Option B+.
Yeah.
Okay.
So Adrienne and Josh, thanks so much for coming and for spending an extra 15, 20 minutes